Chairman, before you interrupt me, kindly take notice that the talk starts 5 minutes later. The story behind this talk is that the European Association of Cardiothoracic Surgery, its council, decided 2 years ago to formulate a statement about the usefulness of the endovascular repair in the thoracic aorta. And in order to make this statement, it was obvious necessity to study the literature, and I was charged in preparing a group which would perform this task. And there were 2 conferences and a lot of mails. And this is the group which was assembled with the Association of the European Society of Cardiovascular Surgery. And I was given the honor to chair this group, but the lion's share of the work was performed by David Chang and Janet Martin from Toronto. They are very accomplished and excellent biostatisticians, and strangely enough, David Chang is the chairman of the Department of Anesthesiology in Toronto. And we had a series of conferences, and we finally formulated the objective. It was the analysis of TEVAR versus open surgical repair. We did not compare it to the no treatment, the conservative treatment. We looked at the impact on the postoperative morbidity and mortality with all these factors stated here, and the impact on the perioperative resources utilization. Of course, the basic is the identification of the trials, and there was a very comprehensive study looking through the old data banks performed by Janet Martin, and then we had to formulate criteria for inclusion of the trials. So we took adult descending thoracic aortic disease, but not thoracoabdominal. We used both randomized and non-randomized, which compare TEVAR versus open, at least one relevant outcome, and in any language. So definitions which you will be encountering now, the non-randomized control trial, this is the study in which the patients are assigned to an intervention, non-intervention, TEVAR versus open, in a non-random fashion. There is an influence there which is very difficult to define. The case control study are the retrospective observational studies which determine the relationship between a particular outcome and intervention, death in TEVAR. And the cohort studies are identifying 2 groups of patients. One had one treatment, the other is the other treatment. These are statistical terms you will be encountering now here. And we are going on the statistical level of evidence. You know all of this material is level A. Is randomized controlled double-blind studies, which are impossible in surgery. You cannot make a huge incision and then do not go into the chest and control the aneurysm. And the randomized controlled studies, yes, they are possible. There are none in the field up to now. So we were mainly relied on the level B of the cohort, case control studies, and the case series. And then we are, of course, losing the strengths of the statistical evidence. And the classification recommendation you're coming up with is this, you all know, this ACC and American Heart Association classification of the class 1, which is very few in between in surgery, and class 2 you have a 2A and 2B, and the 2A is favoring more scientific evidence in favor of. Class 2B is against, and the class 3 is totally against. And this expert document, I'm sure you are aware of it, in Annals of Thoracic Surgery of AATS STS, published in 2008, found on a strength on the classification 1 and the level of evidence of A, only use of TEVAR in acute type B dissection ischemia. And equally strong was the evidence against use of TEVAR in the arch, which has a reasonable open risk. The rest of it is usually 2A recommendation or even 2B recommendations. Shortly to our study, the methods, 2 reviewers, David Chang and Janet Martin, identified trials, extracted data. Then we looked at the bias. This is the usual, the software which was used there. It was all done in Toronto, and the odds ratio which was calculated for the proportions. And then we had 3 categories. We had the multi-center trials, single-center series, and the registries. And we have decided to take a multi-center and single-center studies separately, because in registry they all enter into registry at various points, so otherwise you are double counting the patients. And then we finally performed a meta-regression to evaluate the baseline risk factor imbalances, to see basically heterogeneity of the groups which we are analyzing. There are very severe limitations when you are performing such an analysis because there are no randomized controlled trials available yet, and the INSTAT has not been published yet. Non-randomized controlled trials are always retrospective, non-contemporaneous, and there is a rapid advancement in the field, and there is always addressing a mixed pathology. All of these studies have a total mix of aneurysm, dissections, rupture, trauma. Then very often the description is inadequate, and the duration of follow-up is highly variable. We established the exclusion criteria. We have taken out all the studies which have less than 10 cases, unless it's a very special pathology. We have taken out all combined procedures where something else was done in addition to intervention. We have excluded homemade devices, except if they are more than 20% in the group. We have taken out registries and analyzed registries separately. Thoracoabdominal aneurysm, a totally different disease, and the follow-up which was shorter than 30 days. So we came up with the non-randomized controlled trials. 2,894 papers were screened and excluded by 2,351, so it's a major work. The potential non-randomized controlled trial was 543. And then we sat together and analyzed all of these papers and threw out 491, and we are left with 52 trials in 5,888 patients in the 52 papers, 4 multi-center, 35 single-center, and 3 registries. And the exclusion, once again, medical comparison, if there was no open arm of the trial, the open stenting during surgery, insertion of a stent, hybrid or elephant trunk, because again it's a very special material. We have excluded Marfans by definition. One can discuss about it, but that's the way it was decided. A coarctation of aorta, mycotic aneurysm, very special types, and the type A, and if there was no relevant outcome. The first step is a meta-regression analysis, and it did not show in the material significant impact of baseline age imbalances of outcome. I will explain it later. And the relative benefits did not differ, strangely enough, by pathology. Emergency very elective, historical concurrent study, and interestingly enough, the year of study was not shown to be a factor in heterogeneity. It will be shown again. So the baseline, summarizing the males percentage, the same, coronary artery disease, same in all groups. The only difference was down here, the difference in age. The group with the TVAR was significantly older than the open group. And now you will see afterwards a series of these graphs comparing TVAR versus open treatment. So in the middle there will be this, here is the line of identity, no difference. Each box represents a study, and the size of the box is the amount of patients in the study. The horizontal lines will be confidence limits, and the diamonds will be the aggregate results. For instance, here all 3 registries, here all cumulative data. On the left will be results favoring TVAR, on the right will favoring open, and the odds ratio will be always shown, and the odds ratio, as you know, it's a likelihood of an event in TVAR versus open. Basically, if it says 65, if 100 patients died in the open group, then 65 will die in the group with the TVAR. The registry outcomes only very shortly. Death at 30 days in the registries is highly significantly in favor of TVAR. At 1 year, it is still favors TVAR, but statistical significance is lost. Always when you have the confidence limits and the upper limit crosses 1, then it means that there is no difference. The stroke, no difference. Myocardial infarction, no difference. Renal dysfunction, neither, but the overall incidence of complication is half of that in TVAR versus open treatment, so much less complication and statistically significant difference. Going into trials, non-randomized controlled trials and the multi-center trials here, single center and the overall, they will be always shown the same. You see that the death in multi-center trials is highly significantly favoring TVAR. Equally, it is in the single center trials, and the overall results are highly significantly better with TVAR than with the open surgical treatment. Death at 1 year, it's very interesting now, the movement in the multicenter trial, there is still difference. It is much less. It is 679, basically 68 or something like about 70% versus 100%. And then the p-value is already, statistical significance is lost in multicenter trial. In a single center trial, it is equally lost, although slightly favoring TVAR, and the overall results of the both groups when mixed together, a slight difference in favor of TVAR, but no statistical significance anymore. And 2 to 3 years, the difference disappears altogether. Single center studies, multi-center studies, and overall results are practically identical for TVAR and for the open treatment. Looking at stroke in TVAR group in the multi-center trial was significantly lower in the group with the TVAR. Strangely enough, in a single center studies, there is a higher incidence in TVAR that favors open treatment. And in the overall results, there is basically no statistical difference in stroke between TVAR and open treatment. The major difference beside early mortality emerges in paraplegia and paraparesis. In the multi-center trial, there is a much lower incidence shown here, much lower incidence, statistically significant in TVAR versus open treatment. TVAR causes less paraplegia, which has been repeatedly shown in single-center studies. Single-center studies show the same results, considerable reduction, and a highly significant one, and overall, when pooling the results, also favors very highly TVAR treatment. The same picture emerges when looking at the permanent paraplegia. Again, looking at the line of identity here and looking at the multi-center trial, there is a very major difference between the odds ratio is 0.289 versus open treatment, statistically highly significant. Single centers, strangely enough, they are not significant because of the spread on the results. The overall results show the major reduction of permanent paraplegia, and it is highly significant. Myocardial infarction, which again, it is quite logical. In a multi-center study, myocardial infarction, periprocedural infarction, was lower in TVAR than in the open group. Again, the single-center studies, when analyzed carefully, they show the opposite picture. They have a higher incidence in TVAR of the myocardial infarction, so that the overall picture shows statistically no significant difference in periprocedural myocardial infarction. Renal dysfunction, what is to be expected because of the much longer procedure, ischemia of the visceral organs, shows both in multi-center, single-center, in overall results, highly significant reduction of renal dysfunction with the TVAR favoring TVAR. Reoperation for bleeding is, of course, again, in a multi-center trial, in single-center trial, and in overall, it is highly significantly favoring TVAR, less of reoperation for bleeding. Now, looking at the area of problem for TVAR and the re-intervention. In multi-center trial, there is the higher incidence of re-intervention in TVAR than in the open procedures. In the single-center trials, there is no difference, and when you pool all the results with the red here, you see that no difference emerges at the re-intervention, and there are re-interventions at various times, so this is a weak point of this analysis. This is a very interesting analysis of the heterogeneity of the trial. The meta-regression analysis shows that the year of the study, shown here, the year of the study, and this is the size of the patient samples with the circles, shows no significant difference in the results since 1990 to 2007, meaning that the results remained approximately similar throughout the observation period, and there is no statistical significance here. The hospital length of stay, as expected, in overall shows a highly important reduction in the patients with the TVAR. And so to summarize the last slides, the TVAR versus open study demonstrates, the meta-analysis shows a much lower incidence of death at 30 days, and this difference is highly significant. Death at 1 year is still lower in the TVAR group with a 16% versus 22% for open. but this is not statistically significant anymore. At 2 to 3 years, there is no difference in survival between group with the TVAR and the open treatment. Stroke shows no difference, 5% and 7%, and again the highly significant differences come in the rate of paraplegia. TVAR has cumulative 4% incidence of paraplegia and open treatment 9%, and permanent paraplegia 1 and 5%. Both differences are highly significant. Myocardial infarction, no difference. Renal dysfunction and the transfusion requirements are again highly significantly favoring TVAR versus open treatment. Reintervention shows no difference. So the limitations are very clear, that there are no prospective randomized trials. We still have to wait for this. This is a technique which is in development, so it is hard to go back 10 years and then claim that it has the same importance as the present studies. Non-randomized controlled trials were very retrospective, with historical controls. Overlapping, we could not quite exclude that some of the patients were double counted in several studies, and the procedure is sometimes inadequately described. Inclusion criteria unclear. There are various durations of follow-up. But our summary, which we submit to the Council and to the Association, it's going to be published in JACC in the next month, is that according to the meta-analysis, the TVAR definitely reduces early mortality and paraplegia. It reduces renal insufficiency, re-exploration for bleeding, transfusion, and the hospital length of stay. There may be a reduction in TVAR with the postoperative stroke and myocardial infarction in multicenter trial, but it does not stand the test of the meta-analysis. Survival beyond 1 year is not proven, and the TVAR effects are valid for all examined pathologies. Thank you for your attention.